Treat the individual and not the angle. Glaucoma is a progressive neurodegenerative disease associated with irreversible vision loss. Though the prevalence of open-angle glaucoma is more worldwide, angle closure glaucoma is the dreaded variant, with an incidence of only 25%. The associated risk of blindness is threefold higher in primary angle closure glaucoma. Every clinic has multiple modalities for glaucoma evaluation like intraocular pressure check, slit lamp evaluation of anterior chamber depth, gonioscopy, optic disc evaluation with imaging or direct examination. But gonioscopy is considered as gold standard in glaucoma evaluations since it gives visual clues to the actual angle pathology. Even though it is a readily and easily available clinical tool, what stops us from detecting angle closure? The invisibility and inconspicuous nature of angle closure makes it trickier to pick up. It is extremely skill dependent and subjective. There is associated patient discomfort and is difficult to use in mass screening. ISGEO initially defined an angle with more than 270 degrees of posterior trabecular meshwork obscuration as angle closure. But further studies found that half the population with peripheral anterior synecdoche and glaucomatous optic neuropathy had less than 270 degrees of iridotrabecular contact. Currently accepted PACG classification defines an angle closure suspect as an angle with more than 180 degrees of posterior trabecular meshwork obstruction. In spite of these definitions and evaluation techniques, the incidence of an angle closure attack is alarming. It is an ophthalmic emergency and should be avoided with targeted screening and identifying the prodromal signs. The present standard modality of treatment of angle closure attack is laser peripheral iridotomy. It acts by providing an alternative flow of aqueous in eyes with narrow outlet channels by relieving the pupillary block, lowering the intraocular pressure and preventing incidence of an acute attack. Looking into the literature, studies like SAP trial and few others have found that though laser peripheral iridotomy increases the angle width, significant proportion of them had residual angle closure on follow-up. There are various clinical scenarios demanding laser peripheral iridotomy. YAG peripheral iridotomy is the established standard modality and intervention in primary angle closure and primary angle closure glaucoma. But when it comes to primary angle closure suspects, there is no clarity as to who really needs an iridotomy. Is an occludable angle as simple as its definition? If one can't see the trabecular meshwork, does that push him to a significant risk category? What should be done when an angle closure suspect is unlikely to receive a review examination? The World Glaucoma Association has proposed consensus for prophylactic laser peripheral iridotomy, which includes patients with strong family history, fellow eye with acute primary angle closure, those requiring frequent dilatation, inadequate medical access, frequent travel in whom follow-up is difficult. Now the question rises, is laser peripheral iridotomy the endpoint? Laser peripheral iridotomy comes with its own associated side effects. Transient rise in intraocular pressure, uveitis, hyphema, corneal damage, localized lens damage. Dysphotopsia can be a disturbing visual symptom associated mostly with superior laser peripheral iridotomy due to vasoprism effect of tear meniscus. Numerous studies have been done in this regard. Though few studies showed dysphotopsia was lesser in temporal peripheral iridotomy, no clear-cut predictors have been found for subjective glare. With respect to endothelial changes in laser peripheral iridotomy, specular microscopy did show some decrease in cell count. Cataract progression seems to be faster in laser peripheral iridotomy treated eyes. An ALICE study exclusively involved the asymptomatic angle closure suspects and found that laser peripheral iridotomy practically reduced the risk of progression by 50%. Dr. Vivek Gupta and Dr. Tanuj Dada wrote an editorial on implication of ZAP trial and conducted that laser peripheral iridotomy is effective in preventing progression of primary angle closure suspects. Given the low incidence of development of primary angle closure, both in untreated and treated groups, and even lower rate of sight-threatening events, the implementation of iridotomy in glaucoma screening is not recommended and needs further research. In 2021, the ZAP trial team of authors observed the anatomical outcomes of the same set of patients that were enrolled for the earlier trial. They stated that superior LPI results in significant greater angle widening based on anterior segment OCT. In August 2023, a prospective comparative study between laser peripheral iridotomy versus cataract extraction in primary angle closure suspects was conducted in Nepal. The results favored early cataract extraction over LPI for effective opening of anterior chamber angle. The Andhra Pradesh eye disease study was a landmark longitudinal study conducted in rural southern India in which the authors reported 15-year incidence of primary angle closure disease as 15.87%. The annual progression of primary angle closure suspect to primary angle closure was 4.4%, and primary closure to primary angle closure glaucoma was 5.7% over 5 years. In India, where there is low compliance for follow-up of patients, most doctors prefer an iridotomy as it definitely lowers progression. In spite of all this evidence, laser peripheral iridotomy is neither a cost-effective procedure nor a smart way to utilize resources in managing primary angle closure suspect population. Progression to primary angle closure and primary angle closure glaucoma has been noted in spite of patent peripheral iridotomy. So clearly, we need a smarter approach to this situation. Educate the patient about signs and symptoms of acute angle closure. Assess the need for dilatation frequently. Focused history taking with respect to symptoms and family prevalence. Observe with 6 to 12 monthly follow-up. Treat on case-to-case basis. And finally, it is always advisable to treat the individual and not the angle. Thank you.